All right. Well, the trusty iPhone here says 12:01, so we are going to try to be as punctual as possible and get this conversation started. So, to all of those attendees that have dialed in and are connected and watching us today, welcome. We are very honored and glad that you're here with us today. We're excited to be sharing the next 50 minutes or so with you, and particularly excited to share the perspective of one of Iris's esteemed partners in our effort to end preventable blindness. Let me walk through some logistics here today, and then we will get the conversation started. For those of you who have been on a Zoom WebEx before, you know this is a little different from your typical internal Zoom meetings. All of the participants are automatically muted. They are automatically, your video is automatically off. So that's a setting that we put in place. However, there is a way to communicate. And if you look at the very bottom of your screen, there is a Q&A button. And that is going to be active throughout the entire conversation today. So if at any time you have a comment, a question, anything that you'd like to share with the panelists, that's your opportunity to do so. And we encourage you to take advantage of that. We will be monitoring that communication throughout the entire conversation. And if the timing is right, we will either address that question as it is immediately presented, or we might save it closer towards the end. But either way, we commit to you that if you communicate with us, we'll communicate back with you throughout this. So with that, with those ground rules being set, let's get started. My name is Louis Morrow. I am the Vice President of Sales here at Iris. We've got a couple of other folks here joining me to talk to you about our partnership with community care health centers in Texas, and how we together are helping to end preventable blindness amongst their diabetic population. We're honored to have Yvonne Camarena with us. Yvonne, why don't you introduce yourself to the group and tell us a little bit about yourself and your role there at Community Care.
Sure, Louis, thank you. I appreciate the opportunity to spend some time with you today. I am the Chief Operating Officer for Community Care, and we're located in Central Texas. Travis County and a few surrounding counties is the area that we support. I've been with the organization since 2004, and that was my first opportunity to support community health centers, and I've never looked back. I'm a nurse by training. My background is in quality and compliance, but I really enjoyed the operations side. So for the past 7 years, I've had the privilege to work in community health centers as the Chief Operating Officer. And I can tell you that working in a health center is very unique, and I'm grateful because we know every day we're changing someone's life. It offers us a great opportunity to reach those who may not have been reached with healthcare, and more importantly, primary preventable care before. So it's a very enriching, very challenging work, but it's great work that you see a difference every day.
Yeah, and we are honored to be partnered with you and your team, Yvonne. So thank you for that introduction. As you guys have heard Yvonne mention, they are a community health center. And so a portion of our conversation will be revolving around the unique impact and benefits that the Iris Diabetic Eye Exam can have on a community health center, an FQHC. And you'll hear that through the course of the conversation today. We're also joined by a colleague of mine, Tom Foster, here at Iris. Tom, introduce yourself.
Sure. Thank you, Louis. I appreciate that. I am on the sales team. I handle a lot of our activities in the Midwest. I've been with Iris about 2.5 years. I've been in healthcare sales for about 20 years. So very excited to, I know what's coming. And so I'm very excited for all of you to hear what Yvonne has to share with us today.
Great, thank you. So let's get into the conversation. And Tom, why don't you set the stage a little bit as to the challenge here? This is why Yvonne and her team at Community Care initially reached out to us some years ago. Let's set the stage here, Tom.
Yeah, absolutely. Yeah, we always like to make sure that everybody kind of understands where, why we exist as an organization. Obviously, we assume it's why you signed up to be on this webinar, why you are interested in learning more about Iris and what we do. And that is this problem of diabetes in this country. And you see the numbers that are on the screen there, affecting 1 in every 10 Americans. these numbers here, the 30 million and the 12 million folks with diabetic retinopathy, that's a very daunting number. But the real impact is that when you look at what projections are by many experts, that looking out to 2050, that we expect that 30 million to go to 160, and we expect that 12 million to go to 65 million. So it's only getting worse. We see there that of Americans that have diabetes, 40% of them have DR. Many of them don't know it, and that really therein lies the biggest problem. Because one of the fantastic aspects about this, if there is an underlying silver lining, is that if we're able to detect early enough, we can stop that progression and we can halt that inevitable march towards blindness, and obviously a dramatic changing of someone's life. And so the problem is big. The problem is getting bigger, and so a solution is needed. And so that's why our company was created, and why we seek to partner with organizations like Community Care and many others across the country.
Yvonne, I'm curious your perspective, being there in Texas. Obviously, you know, as part of the diabetes belt, this is something that you guys are dealing with as well. Share with us a little bit of your perspective on that population there in Texas.
Well, I think what's interesting, as with folks who are, whenever you're dealing with disparities, and you know, as a health center, and for some of our colleagues that are probably on the webinar this morning, we know that disparities is one of the key drivers to prevent or you know, for folks to get care. And so we know that anything that we can do when we have engaged, when we have ensured that we have brought someone who has not traditionally had any type of healthcare other than hospital care or emergency room, that one of the first things we need to do is for them to understand the purpose of prevention. And so the work that we're doing along with diabetes is our goal is to always slow down the progression of the disease. And we know that any steps that we take to engage the patient, to have them understand the importance of self-care and managing their disease effectively, is going to be really critical. And that's really why we're having the conversation we are today.
We are in complete alignment with that. As Tom mentioned, that's why we exist, is to identify this disease early. You see there on this slide in front of you, diabetic retinopathy is the #1 cause of blindness in the US today, which is a real shame for many reasons, but mostly because it is treatable if we can identify it early. Exactly what Yvonne's talking about, through that early identification. So let me take a few minutes and kind of walk you through what this solution looks like that has been in place with Community Care there in Texas. We've talked about this diabetic eye exam program. And so just to lay a groundwork so that we're all speaking the same language here today, let me explain what the IRIS solution is, and then we'll go into more detail of a lot of these elements. So what IRIS does, what we've done with Community Care and other folks just like them, is we have designed, implemented, and then maintained on an ongoing basis this comprehensive platform that allows for early identification. If I were to sum it up, instead of asking the patient to go to the test, which is historically what has been done in this diabetic eye exam world, we've now enabled folks like Yvonne and her team to provide the test where the patient already is, and that's in that primary care environment. We know that diabetic goes to see their primary care physician on a much more routine basis than they would go see an eye care professional. So we are empowering Yvonne and her team to do that. How we do that is through a series of consultation, we help decide on some hardware. We'll talk more about camera decisions down the road here today, but we help to implement a camera that then is used to capture images of that patient's fundus, left and right. Those images are then uploaded to our IRIS cloud-based platform. The image capture process, Yvonne will tell you, takes minutes. These are very user-friendly cameras. It is not intrusive to workflow. It is a very simple to use device. Once those images are uploaded to our platform, then there's some technology that happens in the background that it applies a series of algorithm-based enhancements to every image that we ingest, regardless of where they came from and regardless of the camera that they were captured with. We work with a number of different camera styles. That enhancement maximizes, in addition to other features that Iris offers, it allows us to maximize the gradability of our program. One of our main goals is to avoid an unreadable exam. It will never be 100% success, just because there are certain anatomical issues that we as providers have to deal with. But you'll hear in just a minute how successful Yvonne and her team have been in terms of maximizing their readability, which is a key success factor here. Once that technology is applied to the images and that enhancement is completed, then we have a team of certified eye care professionals, ophthalmologists, and retina specialists that are in our Iris Reading Center. Those folks then have access to those images that are captured in that primary care environment. They go through a series of reviews and ultimately will identify pathology. We are FDA cleared to diagnose all levels of diabetic retinopathy and all levels of macular edema. But our interpreting physicians will also return any suspicions of additional ophthalmic pathology that might exist, such as cataracts, glaucoma, wet and dry AMD, and so on. That final result is then compiled, taking all the input from the reading physician, and the result is then sent back to the originating ordering primary care physician. In this case, with Yvonne and her team, we have a bidirectional EMR interface in place. So that result is actually sent back electronically in the form of discrete structured data, and any diagnoses that are present comes back with the associated ICD-10 code. We are electronically closing that care gap through the return of that result back into the EMR. The diagnoses populate a problem list, and all of that takes place. We commit to a next business day turnaround. So if someone at Community Care conducts that exam today, they will have that result back in their EMR by tomorrow. However, oftentimes that turnaround time is much shorter than next business day. So I wanted to walk through that to make sure that everybody had a baseline understanding of what this actually was. We will now divide some of these components up and talk about them in more detail. But now that we have an understanding of what Iris is and what we do, I'd like to ask Yvonne to spend a few minutes talking a little bit more about Community Care, paint a picture of who they are, what their scope is, who they serve, and help the audience understand a little bit about their impact. So Yvonne, share with us.
Sure. Thank you, Louis. I always appreciate the opportunity to talk about the great work that's happening at Community Care. We do serve this past year well over 120,000 individuals within our community, and that's within a 3-county radius. I do want to talk a little bit about the services that we provide. We are a primary care health center, and that is our focus. And we really do believe that primary care really offers a great opportunity for the individuals of the folks who are underserved or in our community have access to good, high quality primary care, and that is the focus of health centers. We have 28 locations, but that doesn't include any of our outreach. We actually have mobile and street teams that actually also go out into the community to serve our homeless population. We also have an HIV primary care clinic that actually serves 7 counties within our center. We have patients that come from all over the United States to receive care. We have a very strong women's health service. We take care of our children, and they're very important to us as well. And we also understand a design of a team-based care approach, and that's really as you'll see as we go on in the conversation around Iris, that this is actually a critical component of what we see in team-based care, and the fact that it's a great opportunity for patient engagement, as I mentioned earlier in the conversation. But we also understand that it is important for everyone to have primary care, and so the majority of our patients live on or below 200% of the poverty limit. So know that that is the population that we're serving. And if we could, we'd be serving many more, and we're always looking for opportunities to maintain high quality care. And, obviously retinal screening falls right into that space as well.
Yeah, that's great. And clearly you guys are doing amazing work there in the Austin area, and you're helping a lot of people. That 120,000 annual patients served is quite an impressive number. And I know that the entire audience that's listening to you is really impressed with what you guys have done and the number of folks that you've helped. Let's narrow that down a little bit, and let's start to talk about helping your patients specific to this diabetic eye exam. I want to share some results with the audience and give everyone an understanding of the type of impact that Yvonne and her team have had on the eyesight of their diabetic population. So what you see in front of you is one of the things that IRIS provides to all of our clients, and that is a customized analytics dashboard that provides Yvonne and her team real-time metrics on the impact of this program. And I'll draw your attention to a couple things, and then Yvonne, I'm going to ask you to chime in here for a little bit. The first thing I'll draw your attention to is that Yvonne and her team have done about 17,500 diabetic eye exams in just a few years. So you can see that they are offering this service to many, many of their diabetic patients. There is more to come, and we'll talk about that in a few minutes about how they're even expanding their services. But you can see that they have helped a significant number of people. I mentioned a second ago about that proprietary image enhancement technology, and that has led to the very, very high success rate that Yvonne and her team have achieved of nearly 96% readable exams. So 96% of 17,500, that's a lot of successful exams. And what you can see as you move from the left to the right is the clinical impact that success rate has directly led to. So Yvonne, talk to us a little bit about the pathology, particularly the retinopathy diagnoses. We'll talk about the IRIS saves also in just a second, but from a clinical standpoint, share with us the impact that this has had on your patient base.
Well, and I'm going to keep, there'll be a reoccurring theme that you'll be hearing throughout the presentation, which is talking about equity. And so what you need to see here, I think what these numbers reflect, which is really important, is the importance of individuals who otherwise may not have had the opportunity to receive an exam. And now that they're a patient of community care and having access to the cameras, they now have an opportunity to have an impact on their care. But I think what's really important in this is, especially on the gradability, and going back to also just I think a real important point in that turnaround time and the closing of the loop. That also offers us, the readability and the gradability of the exam. I just want to touch on that really quickly. It helps by knowing very quickly, if we know that a team member is struggling with perhaps their quality of their camera taken, by knowing that turnaround time, that's the first element that really helps us to ensure that we can touch base with that particular teammate and make sure that we get an understanding of maybe what's causing the problem in their camera reading. So I think that's really important. So I don't want the audience to lose sight of that. But also the number of exams that we've had, and you can see that, and we'll talk a little bit more about it, but with 2 cameras. This is done with 2 cameras, and that we were able to reach 17,000 individuals over these years. And what's really important also is that once the individual has the experience and is able to come back and see how quickly and how easy the exam is for them, we know that they'll come back to us that next year, so they maintain their eyesight because they know that this is a preventable event that we can help them with, and it's something that they can also participate in. And it's also, I think the other piece too, it's not just about the retinal exam is almost like our launching pad to other support and knowing that we can find other diagnoses that they may be having in their eye, not just about retinopathy. And I think that's also the important value here, because we're having an opportunity to look at other areas of the eye that might be having trouble based on this particular screening. And I think that's been very powerful, not only for our patients, but for our teams, our clinical teams, to know that as they're sending their patients for this screening, they're going to get really important information and making sure that they know what's happening with the eyesight of our particular patients. I think it builds on the last point I want to make on here is that it builds on itself. And I think that's the other piece. Once your team is really prepared and are taking the pictures, and they can see the ease of taking the pictures by your clinical teams, it starts to build. We have it, and it'll go into their workflow. And we'll talk about the workflow in just a little bit, so we'll go into a little bit granular approach. But I think those are really important because your clinical providers will start very quickly to see the value of this particular screening and how it helps them in that primary prevention. And when you have great primary care providers, which I know you do, they'll start to make sure that they'll be referring their patients over for the screening as well.
Yeah, great. Thank you. And we couldn't agree more with the impact that you've had, and we're proud of the work that we've been able to accomplish with you. Let me make 2 comments, and then I'm gonna hand it to Tom as he moves us into the next part of the discussion. So those in the audience that have some participation in any kind of value-based care initiatives, whether it's UDS in the FQHC world or any other kind of contract where you have performance targets, 17,000 exams, that's a lot of gaps that have been closed by Yvonne and her team. So, imagine that in your world, if that would benefit you from a HEDIS and compliance standpoint. The other part is on the far right in blue, Iris saves. And quite frankly, that's why we exist. We've talked about early detection and getting that patient in the right chair at the right time. An Iris save is defined as pathology that's been identified through this exam that is deemed to be potentially sight threatening. So in the case of Yvonne and her team, 2,400 patients, had they not had access, and that's been a key theme that you've heard from Yvonne is equity and access. Had these folks not had access to this eye exam at the primary care centers at community care, they presumably would have lost some and likely all of their eyesight. And that's the impact that we are the most proud of, that we've been able to have that type of impact on the lives of 2,400 of the diabetics there at community care. That's what it's all about, folks. And you can have the same impact across your population. So I wanted to share those 2 things. Tom, I'm gonna hand it to you, and I think we're gonna talk a little bit more about that FQHC world that we've mentioned.
Yeah, absolutely. So we heard Yvonne talk earlier about community care specifically. And we know that many of you on the call may be from an FQHC or a similar type organization, but there may be some that aren't. So we wanted to kind of make sure that everybody knew what we were talking about when we threw those acronyms out. So I'm going to let Yvonne kind of look at this class of provider from a more general perspective. Go ahead, Yvonne.
Oh, thank you. Thank you, Tom. Again, just like, I'm really proud, as you probably can tell, to be part of community health centers. We're a really important part of the healthcare fabric across the country. And I think that it's, and if you don't have any history about it, there's so much that's out there that I would truly encourage you to just put in a search for FQHCs, and you'll see that our history starts back on the war on poverty in the 60s. And Dr. Geiger and some of the other founders really brought back an idea that they found that they viewed it actually in South Africa, and they saw that this concept of providing care within the community was the best way to reach those who had never been reached before. And we move forward, and those of you who are community health centers, you know that we're growing every year whenever possible, and we are responsible for reaching a large number of individuals who otherwise would not have any care. I think what's really important, we are non-for-profits. We are trying to reach the most vulnerable in our communities. We are local, and I think that's what's incredible about community health centers. We're of our community, and so we are set where the patients we need to reach live, and our health centers are always in the locations where they need to be available to their community. And that's what's really unique. And what's amazing is the quality of care we provide, that our patients are receiving the same quality of care that we would want for ourselves and our family. And we hope to continue to grow this movement. We see it as a movement because we know that we're providing high quality care. And and we look for great opportunities to serve those in our community. So I strongly encourage you to, you'd be surprised how we're such a large, large health centers in the country, but so many people do not know about us. So if anything today, not only learning about IRIS, but please learn about community health centers, because I promise you that there's someone that you know that needs services, and you may not know that there is a health center just in the community where they live.
We are, again, I'll say it again, it's this population that is the most vulnerable, that does need these services. And so it's these types of partnerships that we have in place with Yvonne and her team that make us particularly proud to have had the impact that we have and will continue to have as we move forward. Let's talk a little bit about the type of patient that this type of facility serves. Yvonne, tell us a little bit about that population and really the impact that you guys are having there.
Absolutely. So, to continue on the conversation about what health centers, federally qualified health centers is a special designation that some of health centers receive throughout the country. They're really important designations to help them with care delivery, but they're also a commitment to quality. So that's really the most important. You can see that we have over 1,400 health centers, and those are, what's important is that they're reaching across the country. And you can see just by this map where they're primarily located. Texas has, even though Texas is large, and we all talk about everything's bigger in Texas, but we do have a large representation as well. But you can tell by this map, when I talk back about the start of health centers, you can see that it started on the East Coast, because the first two health centers were in Mississippi and in Boston, and then it went westward. So we're really proud of that. But what's more important is that not only the 28 million Americans that we serve, but we're also an economic driver. And again, I think that's something that is not realized with health centers, is how much we bring in to the economy of the communities that we're in. So again, it's not only the healthcare, but it's actually the driver that we provide when we are providing care. There's services, there's businesses that get built around, because there's activity, there's healthcare happening. So I think that's also really important, that we are not only providing healthcare, we're a social driver for social determinants of health, but we're also an economic driver. And I think that cannot be lost as well. But also we are there to help those who may be disadvantaged and having opportunity to healthcare. And you see that in the statistics that are on the slide. We are both urban and rural. There's not a space that we will not be a part of. And I think, again, that's also important. And so with the opportunity you have, with IRIS cameras, you can see the potential impact related to that as well.
It's such an essential service that's provided across the country. And as you said, it's not tied to rural, urban, what have you. And I love the theme that you spoke of earlier, Yvonne, about equity. And we've heard a lot about that in the news and been brought to everybody's attention about inequities in our society. And this is, just really a powerful way to make a difference. So I think we're going to go on to the next slide. And, one of the things that we wanted to address is, obviously the world has been turned upside down, and this COVID challenge has been unprecedented for every level of provider that there is across the country. And so we know that it will, that it has diverted, changed priorities. It has changed focus, and rightfully so, right? The treatment initially, thankfully, we've learned a little bit. Now the huge effort towards vaccination, and that taking up a lot of mind space and priority again of providers across the country. And even with all of that challenge, you see the numbers on the screen that community care was still able to achieve through this global challenge. And so wanted to let Yvonne talk a little bit about how they've kind of balanced those two priorities within their organization.
Oh, thank you, Tom. I appreciate that. So as we all know, it's amazing to me. I never thought I would say unprecedented. This has been an unprecedented year, and the number of times I've had to say that, not only to our employees, to our patients, to our community. And you can see even with Iris that we had a really big impact, obviously in April and May, and we all know what happened there. We had to collapse services in a new and creative way. So what happened, obviously, to us, there were three main factors that occurred. We obviously had the pandemic. We had to ensure that our employees and our patients could be safe if they were receiving care. And because of that, we had to ensure that we had the proper numbers and the proper equipment with PPE. Always before, I know all of you who are in primary care, maintaining great inventory was always something we're used to. We're a health center. We know how to live lean. But when the pandemic happened, then we were all looking for ensuring that we had the appropriate N95s, that we had gowns, that we had masks, that our patients had masks. Everyone was left unsure how to manage that. We pivoted very quickly to telehealth and visits, and we had that opportunity. But with that meant there were less face-to-face visits, and you can see that happen to us. So what we were able to do by summer, that happened to many of the folks that we that are other healthcare providers, our PPE started to become much more readily available. We understood the virus more effectively. We knew how to protect our employees and our patients to ensure that we could have care back in our traditional approaches, which was face-to-face. We are a relationship business. Primary care is still a one-to-one relationship approach to services. So we knew we needed to get back, but we wanted to do it safely. So you can see that by June, we started to have a way to do that safely, to take the pictures in a safe manner so that both the patient and our employees were safe, that everyone had the proper equipment to do that, and our numbers were able to bounce back. What was really critical, obviously, for us that happened to us in December was the availability of the vaccine. I'm really proud to say that we are at 96% of our employees did receive the COVID vaccine, and that was critical for us so that we can again continue to maintain that safe environment. Here in Texas, starting on Monday, anyone over the age of 18 is going to be able to get a vaccine, and we're really happy about that, not only for our employees, obviously, but for our community. And we think that'll be instrumental for us to continue to be able to provide the care that we hope to as well.
Yeah, what this really shows, and clearly everyone had a lot of juggling to deal with over the past 12 months or so. And to me, this symbolizes Yvonne and her team's dual commitment to not only keeping herself, her employees, her team, her staff safe, but then also not losing sight of the importance of continuing to deliver this eye exam in the midst of this new environment that she and her team were dealing with. So this is proof that it can be done, folks. And despite the fact that, let's keep our fingers crossed that we continue to come out of this thing with the increasing vaccination rate and other things. It's not over. It is still a part of everyone's reality. And yet diabetes isn't going away and diabetic blindness isn't going away. So it's important to maintain that shared focus on that. Let me pause and just remind everyone of the Q&A function. We've had a couple that have come in during the course of the conversation, so we appreciate that. Don't forget, there's that button at the very bottom of your screen. Feel free to click on it, submit. We will either answer it live through our dialogue, or we will type you a response. So if there's anything that's on your mind, don't forget about that button there. I mentioned a few minutes ago that community care has decided to do more. And while their numbers are already very impressive with, as Yvonne told you, just 2 devices, because of the results that they were experiencing and because of the impact that they were having on their diabetic population, Yvonne and her team just a few months ago made a decision that they wanted to do more. And so we are in the midst of expanding their diabetic eye exam program. And we're doing a few things differently, as Yvonne will talk to you about. One of those is we're incorporating a different camera style. And that's one of the unique things about Iris, is that we are not married to one particular camera or another. We are not actually a camera manufacturer. So we come at this from a very unbiased perspective, and we'll coach our clients through this decision-making process, which is exactly what we helped Yvonne and her team do. So Yvonne, talk to us a little bit about how you arrived at that decision. I know that there were some funding challenges involved, so we'll talk about funding. I know that was a concern from some of our attendees. But then let's talk about the next phase and what you guys are about to implement here, okay?
Oh, absolutely. Thank you. So we had great success with our two tabletop cameras. Just to go back a little bit to explain our health centers, we had two very large health centers, and we placed the cameras in these regional hubs, and so we had great success. And but the issue that we identified is that where we were having less success was our rural locations, and we have some health centers that are large, medium, and small. And obviously, the further out in our county from our urban core are smaller health centers. And that also then created where our patients were having to drive further and further in to get their retinal screening. So clearly, our numbers, the further you got out, were not as robust as folks who were living in our urban core where these two health centers are located. And so we knew that one of the fundamental principles that we approach our primary care is to have our centers where our patients are located. Now we know that not every service can be in every health center, but we realized that we had an opportunity that we could bring the cameras to the health centers as well. And if we did that, we would have a much more robust response because it wasn't that our patients were not engaged, it was they had transportation issues. They could not, for many of us, especially in our rural centers, they may not be able to get out or their rides may not be as reliable. So with that, we also realized that our numbers, the desktops are really great for large numbers, but what could we do so we could also maximize the use of the camera, because we know we also wouldn't be able to afford to have a camera in every center. So what we did is we started to partner up our health centers so that they could go ahead and share a camera. Since they're portable, we knew that, and then we could move those cameras around. And we based that on the population that we had at those particular health centers so that we would know how many centers could share a camera. And that's how we came to the number that we did. So we were really fortunate that our nursing team also are mobile enough that they will be moving the cameras around based on the availability and the need. The great part also, because they're portable, we also will know based on our diabetic appointments or other diagnoses that need a retinal screen, we can also calendar those days so we make sure that camera is getting utilized every day. So we're really excited about that. We're getting ready to kick off the training. The team is really happy about that. And it's also one of those things that because there's the interface component to it, that camera is movable. So even let's say that I happen to be at a site because I'm working is closer, we can still take that picture wherever they are. And that's the great part, because it's in our electronic health record. The patient can go, if it turns out that day is the best day for them and that camera's there, we're there for them, and we can go ahead and get the screening done. And that's the great part about having the multiple cameras that we're excited about implementing. The other last thing I'll say is that because of our success, and we can see the quality of the training that we've had and the quality of the pictures that we're taking, we do believe that we'll be able to transport that idea and that concept, because we have enough staff that are already trained that, again, that this will also build on itself as well.
Sounds like, Yvonne, that you've talked, I've heard you kind of touch on the theme of flexibility, being able to provide what your patients need where they are. And this it sounds like kind of continues to build on that. And that's dynamite. We're excited to see how this rolls out in your organization. Next up, we really want to touch upon something that is very specific to iris. You heard, and we looked at some of the statistics earlier of the really phenomenal gradability we talked about, or readability, kind of this interchangeable words that community care has experienced in using iris and in taking their exams with all of their patients. And there's a number of factors as to why that percentage is so high that they're experiencing. We would, first of all, we'd like to think that it's part of the education that we provide, and the approach that we take as an organization to work with our clients from the very beginning and understanding their workflow, which we're going to talk a little bit more about specifically in Yvonne's clinics in just a moment. But understanding workflow, working with the folks, providing different ways of receiving education, whether that be video clips that they watch at their own pace, whether that be live interactive type things on site or virtual trainings, that the training aspect is really key, that just having a camera doesn't solve a problem. But understanding what to do with that camera, how to talk to the patient about what this camera is about and the benefits of the program, that all of those things roll into being part of the benefit. But certainly one of the other key aspects is what you see on the screen here. And this is something that is proprietary to iris. It's an algorithm that our technology utilizes. And what you're looking at on the left is a typical fundus image. And you see that there's a fair amount of dark shading around the outside on the right side, and that triangle that kind of comes in on the left that's all dark and shaded. That's fairly typical, and it might be a perfectly normal image for someone that has maybe a little bit smaller pupil than others that they may be taking exams for. What we can do is take that image and run it through our proprietary algorithm, and you see what comes out is there on the right, where the vasculature on the upper and lower arcanes are much more visible, so that when our iris reading center physicians, ophthalmologists, and retina specialists are able to see both of those images, they're able to zoom in and really detect and see varying degrees of pathology, whether it be DR, whether it be macular edema, or any of the other pathologies that they may identify. This enhancement technology allows them to be able to really see what's going on and provide a much more accurate report that's going to come back to the clinic, and then obviously that information that will get back to the patient. So really kind of a critical piece here, and we wanted to make sure that everybody understood. So Louis, I don't know if you have anything to add there.
Well, what I would add to that, Tom, is we think about the results that Yvonne and her team have experienced so far. Casey, let's look at the next slide and let's remind the folks at exactly what those results have been. So remember, almost 17,500 exams with 2 cameras, a 96% success rate. Yvonne and her team have helped a lot of diabetics preserve their eyesight. Now imagine adding 9 more units to the existing 2 and the impact that the community care is going to have on their diabetics. It's staggering, quite honestly, to begin to think about how many more diabetics that Yvonne and her team will help to preserve their eyesight. I do want to mention that I know that there's been a question submitted. We heard from some folks even prior to the WebEx about funding. And Yvonne and her team have established a relationship with a funding partner there locally. So that's been what they've been able to rely on. I will share with you that IRIS has a limited time program where we have the availability to offer a free device pilot program. We know that funding can be a challenge. And so if anyone is interested in learning more about that free device pilot program, drop us a note in the Q&A box, come to the website, there's an 800 number. We're happy to share the details of that. It's something that is limited in nature, meaning it will not be in place forever. But for now, we understand that particularly this audience might have some funding challenges, and we want to make sure that you're aware that does exist. And so we've designed this to minimize the upfront capital and to give new folks some experience in utilizing this platform before larger decisions are made to move forward. So I wanted to remind the rest of the crowd about that. I know there are also some questions about workflows. As Tom mentioned, this is about more than just dropping a camera in a primary care clinic. There's not to insinuate that this is hard. In fact, it's just the opposite. Yvonne and her team have done 17,500 exams. If it were hard, she would not have been able to accomplish that. But you have to have the right workflow in place. Part of what IRIS offers is that ongoing consultation from our client support group that helps to coach and helps to offer ongoing feedback and suggestions on workflows. So I'd love for Yvonne, if you can spend a minute or two talking about the decisions that you guys have made over the years, some of the logistical challenges, some of the key success factors that you've experienced in terms of workflow. Tell the group how you designed your program and how it's been so successful.
So I think what's really important for our panel, for our team that's on the call to know is that the most important part that made it easy for me to have success is that we had physician champions. Now, I know we're a large health center, but your primary care provider champion is the most important. And I was fortunate to have our chief medical officer, who was our biggest advocate for this, as well as our physician leaders and even an endocrinologist. She and I have been really trying to increase access to retinal screening for the last 3 years. And you can see that by our numbers, that it was just always in the forefront of what we were trying to do. So how did we do that? I cannot thank enough our physician leadership in our organization to make this possible, because they had to take a leap of faith with us, that they know that if we were taking the medical assistants, and what's really important is that our medical assistants are actually the real champions in this program. They are the ones who take our pictures, and they take a lot of pride in their ability to do this well, because they know what they're doing every day and how important it is. So we make it easy. As I've mentioned before, we believe in meeting our patients where they are. So we have multiple approaches. And our locations take them and use them depending on the populations that they're trying to reach. We obviously, if they have an appointment and it takes just a few minutes to do it, as soon as part of the check-in, if it's time in our team-based care model, we know they haven't had their retinal screening, we're just going to walk them right over and take their picture. So that's obviously the straightest line that we have. We make it part of the care check-in process, and we make sure that they go ahead and have their screening before the provider comes in to see them. So how do we do that? We create standard delegation orders. We created competency with the support of IRIS, so that our medical assistants, they just had to see if it was time for the screening, and they can do that without, they're doing it completely proactively. They don't have to wait for their provider to put an order in. They can do that automatically. So that was really the most important step. We also know that maybe they might not have time that day. So we have fairs for them. We let them know that it's IRIS Saturday and it's Diabetes Saturday, and they come in, and the IRIS program is part of their check-in that day. We created where we have a dietitian come in, talk to them about eating options for them, culturally sensitive eating options. We have our nurses who will teach them about how to use their glucometer. They meet with their provider just to talk about any other referrals that they might need. We have a pharmacist that meets with them to talk about their medication, and our medical assistants are taking their iris pictures as well. The other option we have is maybe the only thing they need is their screening. Our medical assistants have a panel of appointments just for preventative services, and IRIS is one of those services. So they can just call in and make their appointment for the IRIS camera all on their own. So we do everything we can, and we know not one size fits all, not only for our patients, but our community and our providers. If they have a complicated visit, we just look for every way so that we reduce the barriers for them. And what's great about this, again, is especially for your medical assistants, they now feel like they're part of the provider team. And that's something we're really cultivating right now, is team-based care, that the care is around the patient, not around the provider. And that has been really critical. So then that way, every team member takes ownership of that. So it's not surprising that our clinical pharmacists might see that they haven't had their retinal screen, and they'll make sure they get it, and they call the medical assistant and say, hey, I noticed this person is short their screening. We'll see that built in. So our medical assistants that are also care coordinators, you'll see those two roles. And that's what we've seen has really been critical, and we perceive this as a very important gap in care. So that's been our approaches. And so, like I said, we see that as just mainly because not one size fits all. What's great about the camera will go with every type of service that we have related to this. So the camera can go with you, depending on what style works best for you.
And I would just simply add to that, Yvonne, that for the audience, you don't have to figure this out on your own, right? That is part of what you receive when you partner with Iris. And that is, we share these types of best practices with you. Iris to date has conducted nearly 700,000 diabetic eye exams. So we've learned the right and not so right way to implement these programs, and can hold your hand and walk you through. Again, this is more than just dropping a camera in a primary care clinic. And you can see that Yvonne and her team have really refined this process and figured out a way for it to work on an ongoing basis. That's how they've conducted nearly 17,500 diabetic eye exams. Now, I will also add, part of what makes their program so efficient is the fact that they do have a bidirectional EMR interface in place, which provides some of these workflow tools that Yvonne is sharing with you guys. This is not a requirement of an Iris program, but it is certainly a best practice that we recommend, that bidirectional interface. Iris has an industry-leading proven ability to build these bidirectional interfaces with any HL7-based EMR platform. In this case, you can see some of the benefits that Yvonne and her team are experiencing. The fact that the orders are input into the EMR and then auto-populated into the device. So that maximizes efficiency and reduces workflow step and saves time. When the results come on the back end, the results are sent back electronically directly to that patient record in their EMR. It comes in the form of discrete structured data. We're not simply scanning a PDF and inputting it into some random place in the patient chart. This is a predetermined pathway that's part of the custom-built bidirectional interface, which adds to those efficiencies that Yvonne and her team have experienced. As I mentioned earlier, it electronically closes that care gap. It auto-populates diagnoses on the problem lists. And for a number of EMR platforms, it actually can initiate that dynamic financial transaction related to the reimbursement portion of what Iris does. So I wanted to make sure that the audience was aware that this is in place at Community Care. They're actually about to engage in a transition from one platform of EHR to another. They're moving to an Epic platform. And they've seen the value so much in this interface that they want us to help build a new interface for them once they transition to their new platform. So again, while it is not mandatory, you do not have to do this. It is absolutely one of our best practices and a strong recommendation. And as you heard from Yvonne, you can see why it has such a positive impact on their workflows. So we're coming up at the end. I know there's been some questions submitted, so why don't we spend the last few minutes going over some of those questions. One question that seems to have come up a couple of times is reimbursement. So let's spend some time talking about that. Yvonne, I'll get the conversation started, then maybe you can jump in with your perspective, from a community health center standpoint. For a traditional IDN or primary care clinic, this is a reimbursable exam. The environment, as most other reimbursement policies, can change from one part of the country to the next. But by and large, what we've seen from our clients is a very favorable and very positive reimbursement environment. I will tell you that Iris, we are not a billing company. We do not submit any claims either on behalf of our partners or on behalf of our professionals in the reading center. That is assigned over to our partners. So it is our primary care physician partners that are actually submitting claims for the services. And time after time after time, again, in the more traditional IDN world, we hear that this is a very budget positive endeavor based on the reimbursement that is available out there. We know, again, there's some variability from one region of the country to the next. So if you'd like to discuss some more specifics about your portion of the country, we're happy to engage in a more detailed conversation about you, about your area, and about what we've learned based on our clients that are in your area. Yvonne, obviously the community health center angle from a reimbursement standpoint is a little different. I know we've only got about 2 minutes left. So share with us a little bit about your perspective from a finance and reimbursement standpoint.
Right. Thank you, Louis. I'll do this really quickly. I think
Sure.
every, and we had mentioned that every region is different, and obviously, the Medicare rules would apply, and that would apply to us across the board as health centers. And so, so we all know as far as what our payment methodology is related to primary care services and what's included and what can be billed separately. So I think from a health center, and that would be our perspective, I think your panelists, the folks on the call would know that. I will tell you that for us, we do have DSRIP, which is a program that's part of CMS that is regional to the particular states. And in Texas, the IRIS screening is something that is part of our quality metrics that we do receive reimbursement for. So obviously for us, it's really important that we maintain high levels, because you have to sustain those levels of screenings to meet that quality criteria so that you can get the reimbursement related to that. So obviously that is our financial incentive, and for us, it also met, more importantly, with our quality goals that had been set by our chief medical officer. So again, those two partnered together really did help us to ensure that we wanted to move forward with our IRIS screening program. So that is something that was important to us, along with the quality of care that quality measures that have been established by our physician leadership as well.
That's right. Yes, ma'am. And as you have said multiple times, the biggest impact is the pathology that you're identifying and the vision that you are preserving. And the financial benefits only help to sustain and maintain, and in fact, in your case, grow your programs, whether it's a traditional value-based care arrangement or, in your world, from a UDS quality measure standpoint, we know that there's financial benefits as well. Folks, we appreciate your time. I've gotten a number of requests for more information about our free pilot program. So we will be contacting those folks as part of our post-event communication. So we've made a note of those folks that are interested. If you've not submitted that through the Q&A chat, please feel free to reach out to us directly. You see the website links there in front of you. Yvonne, we've been honored, and we really, really appreciate your participation and helping us share your story of how impactful you and your team have been with your diabetics and helping to preserve their eyesight. Attendees, we appreciate it. Thank you again. Enjoy the rest of your day and week, and we look forward to communicating with you again soon. Take care.